Good evening, everybody. First of all, I would like to thank IMA Kannur State Branch for the wonderful opportunity to link with Rela Institute, and it's a great place. We just went around. I'm going to talk on indications for liver transplantation. First of all, liver transplantation is a increasingly performed procedure in India. It not only cures underlying liver disease, but also it transforms lives completely. But you should choose the right patient and the right time for liver transplantation in a patient. The timing of liver transplantation is very important. We all know liver disease, chronic liver disease leads to liver cirrhosis and eventually leads to end-stage liver disease. When they develop end-stage liver disease, they have a liver that is very shrunken, they will be jaundice, they will have ascites, and they can develop a hepatocellular carcinoma. So when these conditions develop, the patient should be considered for liver transplantation. Or when they have hepatic encephalopathy, that's another indication for liver transplantation. But there are certain things that can be very subjective. So therefore, we use what we call as model for end-stage liver disease score, MELD score, which is more objective, devised by Professor Patrick Kamath, who is in this picture with us. So as the MELD score increases, the mortality increases. So generally, we consider patients for liver transplantation when the MELD score is around 14 or 15, like that. Because the more higher the score goes, the mortality is much higher. However, there has been a lot of changes in the indications for liver transplantation over the years. This is due to increasing number of obesity, fatty liver, there's more alcohol in the community. Therefore, the indications have been pretty much changing, evolving, and a lot of new drugs for hepatitis B and C have come onto the market. So let's talk about alcohol-related health problems. It is there worldwide. And in India, we are not any exception. Particularly the southern states account for close to 45 to 50% of alcohol consumption in the country. And predominantly in India are hard liquor drinkers compared to the West. And we do anything to get alcohol. And the spectrum of liver disease in alcohol varies from sort of simple steatosis and to steatohepatitis. So this condition is called alcohol-related steatohepatitis, and that can eventually lead to cirrhosis, liver failure, and liver cancer. We'll come to this situation of alcohol-related hepatitis in a bit. So in Europe, the most common indication for liver transplantation is alcohol-related end-stage liver disease. But it's not as easy as that, because there are certain rules when it comes to liver transplantation for alcohol-related liver disease. The patient should have advanced liver failure, end-stage liver disease. The MELD should be above 14. The most important is there should be complete abstinence for at least 6 months prior to the surgery, because this tells about the spontaneous recovery of the liver. Also their attitude towards alcohol, that they will remain alcohol free in the post-transplant period. And of course there should be no other substance abuse, and no underlying psychosocial problems, and of course good family support. So these things are very important for liver transplantation in alcohol-related liver disease. However, last 5 to 10 years, there has been a lot of changes in the disease spectrum, what we are seeing now. So the two conditions that most of you have seen as well is called alcohol-related hepatitis and acute on chronic liver failure. So what is alcohol-related hepatitis? This occurs in prolonged heavy drinkers, and usually in the presence of background cirrhosis, and in severe cases this can lead to alcohol-related acute liver failure, basically acute on chronic liver failure. So alcohol hepatitis, the patient will be severely jaundiced, they will be coagulopathic, they may or may not have ascites. If they have ascites, that condition becomes worse, and it's called ACLF, acute on chronic liver failure. If they don't have ascites, it is alcohol-related hepatitis. And the worrying thing is the mortality can vary anywhere between 10 to nearly 80-90% mortality. If they have severe alcohol-related hepatitis leading to ACLF, the mortality can be as high as 90% within 6 months if they don't get better. So when you see these patients, it's important to tell them about abstinence and other treatment. In 1997, if somebody with heavy alcohol consumption requiring transplantation, if they do not remain abstinence from alcohol, and there would be a contraindication for liver transplantation. So that is, severe alcohol-related hepatitis was a contraindication for liver transplantation until this trial, which was published sort of 10 years ago, that showed patients with severe alcohol-related hepatitis, if they don't get better, then they'll require benefit from liver transplantation. This study in NEJM showed a clear survival advantage. The reason for this is there is no clear-cut treatment for alcohol-related hepatitis. So what we do is, the protocol is we give corticosteroids because alcohol hepatitis is a highly inflammatory condition. So therefore you biopsy them, make sure there is no sepsis, and then you give them course of steroids. If they respond, they do very well. If they don't respond, there is absolutely no treatment for alcohol-related hepatitis until now, and the only treatment is liver transplant evaluation. Therefore, patients with alcohol hepatitis, even if they are not abstinents, they will require liver transplantation. But this patient should be carefully selected. Not everybody with alcohol hepatitis will go in for liver transplantation. And in worst case scenario, they will develop acute and chronic liver failure. The blue line is ACLF. If you don't treat them on time, they will lead to severe mortality. They will just die straight away. So you have to intervene at optimal time. So in patients with ACLF, usually you have to assess the need for liver transplantation between first 7 days. If you can assess, there are various scores for that. If you can assess that, and then if you consider for the surgery, then that would be the ideal treatment for them. So therefore, the guidelines are changing now. So in patients selected for liver transplantation, particularly with alcohol liver disease, you don't have to be abstinent for 6 months. There are studies to show 3 months abstinence is more than enough. And at the same time, in alcohol hepatitis, there can be patients with no abstinence or recent abstinence. And we see this in our own experience as well, because this is a patient who presented with acute and chronic liver failure, with severe jaundice. He had very high creatinine, completely coagulopathic, and after transplant he changed completely to a model. So alcohol liver disease, alcohol hepatitis, liver transplantation changes life. The other condition which we increasingly seeing is fatty liver disease. So basically the pathogenesis of fatty liver, that's why it's called non-alcoholic fatty liver disease, because it's very similar to alcoholic liver disease. And recently we've seen increasing prevalence of obesity, type 2 diabetes, and fatty liver disease. And almost majority of them who have fatty liver have non-alcohol related fatty liver, and 1/3 will have alcohol related fatty liver. The pathogenesis is more or less similar. Whether you eat too much or drink too much, the damage is similar, the same. So somebody who has fatty liver, the disease progresses to NASH, particularly if the age is advancing and if they have underlying type 2 diabetes and obesity. So 90% of patients with type 2 diabetes and obesity have underlying fatty liver disease, and this can progress to liver cirrhosis, liver failure, and liver cancer. And in fact, Western study from the US showed that NASH is increasing as an indication for liver transplantation, almost 170%. And we analyzed our data. We found that NASH patients coming in for transplantation, there's a huge increase in the number of patients for liver transplantation. We've seen that there has been increase by 266% from 2014. And you can see the other diseases are more or less similar. The problem with NASH is these patients are, they have advanced age, they have underlying diabetes. More worryingly, they have underlying coronary artery disease. So NASH patients have very sick, very high risk for coronary artery disease, and in future, now we can say no to them for transplantation. In future, we cannot say no to them. And we used to talk a lot about viral hepatitis. Those days have completely gone now. Hepatitis C until 2014 was the leading indication for liver transplantation, but it's no longer now. And it's been completely taken over by NASH. And NASH, as I told you, have increased coronary artery disease, and obviously these patients are quite high risk when they come for a liver transplantation. NASH is also an independent risk factor for hepatocellular carcinoma, apart from obesity and diabetes. Therefore, if you're obese and if you're diabetic, that itself will make you risk of developing HCC. Whereas in addition to that, if you have underlying NASH, that's also an indication to develop hepatocellular carcinoma. And when it comes to transplant in hepatocellular carcinoma, of course, hepatocellular carcinoma is cured by liver transplantation when they follow certain criteria. There is something called the Menon criteria. There is a UCSF criteria. When you follow these criteria, the survival advantage of liver transplantation for hepatocellular carcinoma is as high as 75% 5-year survival. And there are a lot of newer therapies for hepatocellular carcinoma, like chemotherapy, immune checkpoint inhibitors, and the tumors can be downstaged and patients can be taken up for liver transplantation. Just last one slide on acute liver failure. This is a life-threatening emergency where liver failure develops in somebody with no known underlying liver disease, and these patients were treated by liver transplantation as an emergency, but there is an increasing utility of therapeutic plasma exchange in these patients so that you can avoid liver transplantation in a significant proportion of patients. So to conclude, the indications for liver transplantation are continuing to evolve. What was a contraindication before now has become an indication, like in alcohol-related hepatitis, and we all know that obesity is on the exponential rise, and NASH is the leading indication. As a result of that, patients develop NASH, non-alcohol-related steatohepatitis, and that can progress to end-stage liver disease, and that is the leading indication for liver transplantation in our country. Of course, then these two, alcohol and NASH, are completely lifestyle-related disease. Therefore, exercise and diet are completely mandatory to avoid this deadly liver conditions. Thank you.